we've tried to set up systems, staging systems, risk factors, pathways to define which cancers to worry about the most. There are different staging systems. The AJCC staging system is one. The Brigham and Women's Hospital, BWH system, is another. The one that I tend to use the most is the NCCN system, which stands for the National Comprehensive Cancer Network. They turn out guidelines of treatment of virtually every kind of cancer. This is the one for squamous cell skin cancer. It's almost identical. The chart is almost identical, except for a few words here and there, for basal cell cancer. Why I like this system for classifying the risk is because it doesn't just use a few measurements of the tumor. It takes into account the patient who's getting the cancer as well. And that's really important in a disease where most patients do very well, but a few are very susceptible to an aggressive cancer with a bad outcome. What do I mean? So first, if we go down these groups and look at low risk, high risk, and very high risk, you see the first thing is the size of the tumor, but also where it's located. It turns out that it's tougher to take care of a basal or a squamous cell cancer in some parts of the body than others, mostly because there's just less skin to remove. It's harder to do a wider removal, and there's more cosmetic impact. There's more deformity if you're talking about the face, the fingers, the skin right above your tibia, which is your shin bone, and the anogenital region. So if you've got a large tumor on your abdomen, your back, your upper arm, a surgeon like me can take a big chunk out of that, get it completely removed, and almost always cure it. But the same exact size tumor on some of these other areas may be much harder to get a big margin around it. And we're going to have to use a little bit of a more conservative technique. And we have to know how we can do that and get the same results. Now, some of the other things, already mentioned this in the pictures, stands to reason that the more well-defined the tumor is, the easier it is to get it out, the higher the likelihood that you've cured it. If the cancer's already come back once, it's at high risk of coming back again. And then we start getting into patient factors. Is their immune system normal or suppressed? Any one of these things, you don't have to have all of them to be high risk. Any of them make you high risk. So you could have a small, well-defined primary tumor, but if your immune system is not normal because you had a kidney transplant or you're on very powerful immunosuppressive medications to treat any of a number of conditions, including cancer sometimes, then you are already at high risk that your cancer might not be removed and cured with a simple surgery. If you had prior radiation or some chronic inflammation and the tumor is growing there, again, high risk. And if it's growing very rapidly or causing neurologic symptoms, these are really high risk factors. Then most of the others are more technical factors that the pathologist would look at and measure and can help us understand when a tumor is high risk, when it looks like to the eye everything is okay, but they see cells, for example, going into a nerve, because the nerves travel back, quite a long way back to your brain. We've seen skin cancers try to grow along that nerve. When they do that, it often causes neurologic symptoms, and that is a bad sign. And when we see those tumors actually growing in that nerve, it's an even worse sign. So the goal here isn't to talk about memorizing these, to recognize that the outcome of squamous and basal cell cancers is a combination of what's the tumor like and what's the patient like.